Let's now continue our discussion with the sympatholytics. Sympatholytics are drugs that inhibit postganglionic functioning of the sympathetic nervous system. Before we talk about these, I want to talk about the alpha-2 receptors again. Do you remember what the action of an alpha-2 receptor is? Now, I want you to recall from earlier that activation or stimulation of these alpha-2 receptors actually leads to a decreased sympathetic outflow. So even though these drugs stimulate the alpha-2 receptor, they're actually going to inhibit sympathetic nervous system function. So we can demonstrate this with a picture. If we activate the alpha-2 receptors, we're going to decrease our catecholamine production, our sympathetic hormone production, which is going to have an effect on a blood vessel. So ultimately, we're going to lead to vasodilation and a decreased blood pressure. Now we can throw in some drugs here. Clonidine and alpha-methyl-dopa are centrally acting alpha-2 agonists. These drugs are used to treat hypertension, especially in patients with renal disease because they do not decrease blood flow to the kidneys. Now, how do I remember this? I remember clonidine by thinking of Star Wars Episode 2, Attack of the Clones. So alpha-2 is clones. So clonidine stimulates the alpha-2 receptor, which reduces episodes of hypertension. Another note is that alpha-methyl-dopa here is used to treat hypertension in pregnant patients. We need to continue our discussion on drugs that affect these alpha and beta receptors, and now we encounter the alpha and beta receptor blockers. We'll begin with alpha blockers here. These drugs do exactly what their name implies. They're going to block the alpha receptor stimulation. There are three main categories of alpha blockers. We have the non-selective, as you can see here. We've got alpha-1 only and alpha-2 only. A non-selective alpha blocker will equally block alpha-1 and alpha-2 receptors. A non-selective alpha blocker includes phenoxybenzamine and phentolamine. Now, phenoxybenzamine is an irreversible alpha blocker, meaning that high levels of catecholamines cannot overcome this blockade. So how is phenoxybenzamine used clinically? Here, it's used during a pheochromocytoma resection. A pheochromocytoma is a tumor of the adrenal medulla, which produces large amounts of catecholamines. Here we see a normal kidney, the adrenal gland on top, and then we've got a spiky-haired afro tumor that's going to represent our pheochromocytoma. So here, a patient with this type of tumor may present with symptoms of a ramped up sympathetic nervous system. We may see high blood pressure, heart palpitations, anxiety, sweating, and headaches. So this patient's got sweating and headaches now. Now, we need to treat her pheochromocytoma. Phenoxybenzamine is given prior to surgery to block the alpha receptors. So here, we've got an alpha receptor, and we've got phenoxybenzamine. It's going to come in and block these. So when the catecholamine secreting tumor is removed, any accidental surge of the catecholamine release will not have any adverse effects on the body. So side effects of phenoxybenzamine can include orthostatic hypotension and possibly reflex tachycardia. Phentolamine is going to be a reversible alpha blocker. So it's going to be used for patients to prevent MAO inhibitor or tyramine adverse interactions. So remember that people taking MAO inhibitors should avoid foods that contain tyramine, like cheese. So this is because MAO inhibitors prevent the breakdown of catecholamines. So these patients shouldn't consume catecholamines like cheese that will further increase catecholamine synthesis. Let's move on to the selective blockers now. How are alpha-1 blockers named? Alpha-1 selective drugs typically end with osin, as you can see here, and these include prazosin, tamsulosin, doxazosin, and terazosin. Recall that alpha-1 receptor stimulation mediates vascular smooth muscle contraction. Alpha-1 receptors can be found on blood vessel smooth muscle. So let's draw this in. When these alpha-1 receptors are activated, it causes vasoconstriction, which can lead to high blood pressure. So it should make sense that the primary application of an alpha blocker is going to be in the treatment of hypertension. Building off of this concept, alpha-1 blockers can also be used to treat urinary retention and BPH, benign prostatic hyperplasia, since they're going to relax smooth muscle in the prostate, which in turn allows urine to pass more easily through the urethra. One of the alpha-1 blockers, tamsulosin, tends to be more specific for blocking alpha-1 receptors in the prostate. So you're not going to have as much of an effect on blood vessels as you see here, but you're going to have a greater effect on the prostate. So that's an excellent drug to associate with BPH treatment. Certain alpha blockers can be used to treat post-traumatic stress disorder as well. Side effects of these drugs tend to include first-dose orthostatic hypotension, dizziness, and a headache. Now let's take a look at the alpha-2 selective blockers. Hopefully I've driven home the point that alpha-2 stimulation decreases the sympathetic outflow. Thus, if you block these alpha-2 receptors, you're going to lead to an increased outflow of catecholamines. So mirtazapine is an alpha-2 selective drug that's going to be used to treat depression. Toxicities include sedation, increased serum cholesterol, and enhanced appetite. Coming in hot, we got a 40-year-old hypertensive male complains of urinary retention from BPH. What medication will treat both of his diseases at the same time? Oh, think you got it? We just discussed that alpha-1 selective blockers, or the drugs ending in osin, such as prazosin, terazosin, and doxazosin, can be used to treat high blood pressure and urinary retention in BPH. However, remember that we said that tamsulosin is more specific to the prostate, so it won't have as much of an effect on the blood pressure, so the tamsulosin may be excluded, but the other alpha-1 selective blockers would be an excellent option in this case. The concept of epinephrine-phenylephrine reversal is going to be important when talking about alpha-blocking drugs, and this is a commonly tested subject on the USMLE. These graphs will make you apply multiple concepts to figure out what's going on. It demonstrates the effects of an alpha blocker, like phentolamine, on blood pressure responses after epinephrine and phenylephrine are given. So I'll show you what I'm talking about. Let's take a look at the first graph here. In these first two graphs, we'll focus on the drug epinephrine. You can see that one graph represents an epinephrine response before blocking the alpha receptors, and the other shows the response after blocking the alpha receptors. Can you name the two alpha blockers that we just talked about? Hopefully you're thinking phenoxybenzamine and phentolamine. Now from earlier, we saw that epinephrine has alpha-1, alpha-2, beta-1, and beta-2 effects. So here we see a large dose of epinephrine given. So epinephrine is going to be given before we block any alpha receptors. So the blood pressure is going to increase here because the epinephrine stimulates alpha-1 receptors, causing vasoconstriction. So notice here how the alpha-1 effect of vasoconstriction is going to beat the beta-2 effect of vasodilation. So epinephrine is going to affect both of these. However, the alpha-1 response is going to win. So thus, we have vasoconstriction. The net effect is going to be an increase in blood pressure due to vasoconstriction. Now let's take a look at giving epinephrine after we block alpha receptors. The rise in blood pressure seen with epinephrine here is going to be reversed in the presence of phentolamine, a non-selective alpha blocker. This is because phentolamine blocks the alpha component, or the vasoconstriction component, up here. So what's remaining is only the beta-2 response, which is going to be the vasodilatory component. So we're going to have a decrease in blood pressure. So let's do another example. Here, we have phenylephrine acting primarily on alpha receptors. So phenylephrine is going to be alpha-1 more so than alpha-2. We're not going to see any beta receptor effects. So like epinephrine above, up here, phenylephrine also initially increases blood pressure due to its alpha effects. However, it is a pure alpha agonist, so when phentolamine is applied, the blood pressure is normalized, but there is no hypotensive effect, as with epinephrine, since there is no beta component to the phenylephrine. These details are important to know because a lot of Step 1 pharmacology questions will test your knowledge on what meds act on what receptors and how these different meds can interact with one another.